uh, very polite. If you feel any pain, let me know. Do you have any pain anywhere? So after that, you will start. So here, obviously, as they mentioned that you have to see the face of the patient and then proceed. So the facial features in this patient is long, thin face. This is known as hollow face, also known as hatchet face. These are different names for this type of face, also known as Myotonic face. So long, thin face with temporal muscle wasting and ptosis and frontal baldness. So these are very obvious here. So you can just uh, slightly with your very low sounds, you can repeat these things. The patient is having uh, baldness, patient is having muscle weakness of the face, their muscle wasting is there, or the temporal area, or this facial muscles, and face is looking like long, thin face, hollow face, so hatchet face. So these things you can repeat, and then you will get the confidence also. Okay. The muscle wasting especially will be present in temporalis muscle, in the masseter muscles, and sternocleidomastoid muscles, and the distal limb muscles. Okay. So, so these are the findings that you have to confirm also in these type of patients. When you entered and you shake hand with the patient, and ideally we should shake hand with the patient. In such patient, we should. So when you shake hand with this patient, he is having difficulty in releasing the grip. So releasing the grip is very difficult. So from here also you can confirm that the patient might be having this myotonia dystrophica. Okay. Then in the face, again coming back to the face, so ptosis, check for the drooping of the eyelids, how far it is down, and how much it is covering the uh, sclera. So okay, and then you have to ask the patient to smile, puff out your cheek, and close your eyes tightly. These are the three tests you have to do to check the facial muscles power. Okay, so he will not be able to puff out of the cheeks. It will be very weak. When he is closing his eye tightly, there will be release of the eye muscles will be very late. So eye opening will be very slow. Okay, still we are in the mouth. We have to ask some words to repeat. The patient will be having dysarthria, or the slurred speech will be there. Dysphagia, directly you can ask the patient, do you have any difficulty in swallowing? So he must say that yes. So there is aspiration risk always there in such patient due to dysphagia and dysarthria. So they can present with aspiration pneumonia also. Okay. Then we have to do motor examination of the limbs. You can do upper limb. So the tone inspection, there will be muscle wasting in the distal muscles more, and then you have to see the tone. So there will be hypotonia in these patients, especially in distal muscles. Power, the distal muscles will be weak. Distal muscles will be weak. Power will be weak in the distal muscle. Like the grip strength and the ankle dorsiflexion will be weak. Okay. Then the reflexes will be reduced or absent. Will be reduced or absent. Will not be normal. Coordination, usually it will be normal. Coordination will be normal. And sensory system will be intact. So this is the limb examination. Then once we pick up the diagnosis that it is myotonia dystrophica, we have to think about other systems involvement in myotonia dystrophica. So one is the cardiac. We have to do the auscultation, especially we have to look for any placement of the uh, pacemaker. If there is, then it is also going in favor, and it is indicating that the patient is having conduction defects. These conduction defects can occur in the form of either bradycardia, bradyarrhythmia, or tachyarrhythmia. Okay, so and the features of cardiomyopathy could also be there. Then the respiratory muscles weakness could also be there. So check the chest. How is the chest? Chest muscles could also be looking weak, or the atrophic muscles. And if you will ask the patient to take a deep breath in and out, you will see the very shallow breathing or weak, looks like weak. Endocrine manifestation is there. So mainly the endocrine manifestation will be in the form of diabetes or hypogonadism. Okay. So You have to see the finger digit for finger prick of this glucose testing frequently. So these may be present. Okay, and then you have to examine the axillary and the pubic hair, and you have to inform the examiner that I would like to examine the patient for testicular atrophy. Gynecomastia, which could also be there. The patient could be female also. So in that condition, there will be ovarian dysfunction. Right. So these are the extra neurological manifestation, you can say. Okay. So cataract also should be checked. Cataract could also be present. And the cognitive impairment, mild to moderate, intellectual disability could also be there. Okay. Then once you finish your examination, the examiner will ask you what is your findings and what is your diagnosis. So you will tell these findings confidently, and you will inform that the possible diagnosis in my case is myotonia dystrophica. Okay. Then the next question automatically will come: what is the differential diagnosis? And please remember the differential diagnosis to not to lose the marks, because in this case you should get the full marks if you know this myotonia dystrophica. So cover this from A to Z. So don't lose the marks from clinical communication and clinical judgment and differential diagnosis. So the other differential diagnosis in this case could be other myotonic disorder like myotonia congenita, and the second other myotonic disorder is paramyotonia congenita. So both are congenital diseases. Then other differential diagnosis, muscular dystrophies, that includes fascio-scapulohumeral muscular dystrophy, and the second one is limb girdle muscular dystrophy. Then there could be other differential like mitochondrial myopathies and glycogen storage disease. Then neuromuscular disorders, amyotrophic lateral sclerosis, spinal muscular atrophy. These are enough, but if you want to more slightly, you can think about hypothyroidism and Cushing syndrome. But these are will be very less likely to be included in the, but it is included in the differential diagnosis. Investigations. The next question will be how you will investigate the patient. So the genetic testing will be the confirmatory test for CTG repeat expansion in the DMPK gene. Okay. Then the next test you will say electromyography that will show the myotonic discharges. And there is a specific word for this. In the EMG, you will see dive bomber potentials. Dive bomber potentials that are specific for myotonia dystrophica. CPK or CK, very important. It will be 3 times.
Can you repeat, sir? Dive.
Okay, I will write in the chat. So this is EMG, dive bomber potentials will be there, and it is equal to myotonia dystrophica. Yeah. It means it is one of the diagnostic features in EMG. And we have to do in suspected case of myotonia dystrophica this EMG. Otherwise, mostly you will say to the examiner that the diagnosis is clinical plus genetic testing. Mostly it is enough to make the diagnosis. Okay, but some other tests, EMG and CPK or CK. Okay, we have to do CPK 3 times, 1 month apart. Okay, if CPK is high with these features, then it is again favoring the diagnosis of myotonia dystrophica. Other enzymes can also be elevated, not only CK, CPK, but transaminases, LDH, aldolase can also be elevated. In the investigation, you can include the muscle biopsy also. Okay. Then, because the patient is having other features, if cataract is suspected, we can do the slit lamp examination and ophthalmological input will be taken. Cardiac is very important to know. So first say the ECG, then echocardiogram, then pulmonary function test, and then the endocrine worker for diabetes and gonadal hypogonadism. So for diabetes, you have to say fasting blood glucose, HbA1c, and urine dipstick for glucoseuria and proteinuria. Then for hypogonadism, we have to see FSH, LH, and testosterone in male. In female, FSH, LH is estrogen, and progesterone and testosterone. So these are your investigation panel. So once the examiner is asking you what is the management of this patient, so you can start like this. There is no curative treatment for myotonia dystrophica, but our goal is to decrease the disease progression and to control the symptoms and to maintain the muscle strength. So I will make the multidisciplinary team. So if you will go like this and if you say like this, it will give very good idea to the examiner that the candidate knows about the disease pattern and the disease progress and disease management. Sorry, my tea is becoming cold, so I'm just taking the sips also. Right, so you have to make the multidisciplinary team that will include the occupational therapist, physiotherapist, the nurse, a specialized nurse, social worker, neurologist on board, diabetologist, cardiologist, psychologist, genetic counselor, ophthalmologist. So this is your multidisciplinary team in case of myotonia dystrophica. Right, then you already said that we have to maintain the muscle strength, we have to control the disease progression, okay, and we have to treat the complications. So complication is coming in the form of diabetes, cardiomyopathy, conduction defects, eye manifestation, and hypogonadism. So these all. Okay. We have to keep the patient active. If the patient is not active, the muscles will become weaker, more faster than the usual. If the patient is having ptosis, we have to send the patient for ophthalmologist also for corrective surgery. Okay, for distal muscle weakness, physiotherapy, occupational therapy. For treatment of diabetes, diabetologist. Cataract surgery, cardiomyopathy and conduction defect, we have to send to the cardiologist. And many the permanent pacemaker and many the ICD. If there is tachyarrhythmia, so you may need the ICD. Okay. Then in the treatment, specifically, the question comes, do you know the medicine or the drug that can decrease the progression of the disease? So it is anabolic steroid and creatinine monohydrate that is used in myotonia dystrophica. So this is one of the examiner's question that is very important to know. In certain diseases, I will give you now the diseases also in which you have to remember the name of the medicine that they use to us specifically. Okay, so the first one is myotonia dystrophica, anabolic steroid and creatinine monohydrate. Okay, in tuberous sclerosis, you have to remember the mTOR inhibitors, sirolimus, rapamycin, everolimus. Okay, in autosomal dominant polycystic kidney disease, you have to remember tolvaptan. In facioscapulomuscular dystrophy, facioscapulohumeral muscular dystrophy, one medicine is effective that is known as albuterol. Albuterol. In retinitis pigmentosa, remember the drug vitamin A and DHA. Other medicine that can help includes phenytoin in myotonia dystrophica. Okay. These type of patient, they are at risk to develop the cardiac and the pulmonary complications. So if they are going for surgery, it is very difficult surgery for them. They cannot tolerate the general anesthesia. Okay. And the newer treatment modalities, you can think about somatic gene therapy. And please remember, these patients, they will need the genetic counseling because it is autosomal dominant condition. So they should be referred. They must be referred. You should include in your plan that I will refer this patient to genetic counselor. Okay. One of the rare examiners question: can myotonia dystrophica patient have a baby? So answer is yes. We can retrieve the sperms or the ova, and we can go for in vitro fertilization. So these are the questions. Okay, genetic counseling is also advisable not only for the patient but also for the family members. Some people, they might not have the full disease like, but they have got the genes genetic mutation in them. So we have to recommend like this. Okay, another rare examiner's question: can we make the prenatal diagnosis? Prenatal diagnosis. For example, if the mother is having like myotonia dystrophica or the father is having the myotonia dystrophica, and the couple is expecting the baby and there is pregnancy going on, so we can make the diagnosis prenatally. Yes, by amniocentesis we can do it, and we can do the genetic testing in the amniocentetic material, whatever we took, we can make the diagnosis. Right. So these all about this case. And let me finish this case, then we'll proceed to the next case. They can ask you what could be the complication of myotonia dystrophica. So remember the cardiac arrhythmias, respiratory failure, aspiration pneumonia, and increased risk for anesthetic complication if the patient is going for some surgery unexpectedly.
For more detailed explanations and related topics, we invite you to watch our videos on our YouTube channel. Don't forget to like, comment, and subscribe to stay updated with our latest educational content. Thank you.